Hello, everyone. Good afternoon. So welcome everyone to the April Town Hall. Before we begin, I have a few housekeeping notes. If you experience any technical difficulties today during the call, please contact my colleague Justine Springer. Her email address will be added to the chat soon. We are recording today's meeting, and a posting of the recording will be made available on the MHCC website. We're looking forward to having a robust discussion during today's town hall. But until we get to the discussion portion of the meeting, please remember to mute yourself. So we will not be holding a formal roll call today, but we're very excited to welcome everyone. We've had around 134 people register for today, including 72 representatives from health information exchanges and 35 individuals from electronic health networks. We also have 8 representatives from payers in Maryland, a few folks from the Maryland Department of Health, and many other stakeholders. So since we're not going to go through a formal roll call, during the discussion portion of today's call, please introduce yourself and your organization before speaking. So you're also welcome to update your name on Zoom to indicate your organization. And the chat feature for today's meeting is on, but we encourage attendees to participate in the discussion portion. And we also encourage folks to please keep the discussion focused on the implementation of the law. So before I begin reviewing the agenda, I would like to offer our Executive Director, Ben Steffen, the opportunity to say a few words.
Thank you, Anna. First off, I want to recognize our colleagues from the Department of Health that have also joined us and have a key role in implementation of the legislation that we call HB 812. I also want to thank all of our staff, including Anna, Nikki, David, Justine, and Kelly, for all of the work that they've done. They've truly devoted a major part of their work with the Healthcare Commission over the last year implementing this. And I think it's paid good dividends because I do see, although there continues to be concerns on the part of health information exchanges, at least, much more relaxed, much more of a view that this can be done, which wasn't what we heard initially. That change in perspective largely goes to the individuals that we're going to be talking with today, but it also goes to the commitment on the part of our staff. Still have a lot to do, and I'll look forward to the input we hear today. Turning it back to you, Anna.
Thank you, Ben. We also have with us today David Sharp, our Center Director. David, would you like to share anything as well? Oh, you may be on mute, David.
Oh, thank you. I would just build on what our Executive Director noted, and also want to express a great deal of thanks and gratitude to the Electronic Health Record Association and its members. We have worked extensively with this group and their members as part of the association, and then individually to try to address questions and advance the efforts of everyone to meet the requirements in the law. So thanks to them and everyone else on the call today. We have made good progress as a group, and I think we still have a ways to go, but we are climbing the hill and we're consistently climbing. So thank you all for joining us today, and I'll turn it back to Anna.
Thank you, David. All right, so next I will briefly provide an overview of the agenda for today. So we will provide a brief snapshot on state abortion laws, review the aims of Chapter 249, provide an update on the status of the regulations, and then we will hear from an HIE attending today's meeting who's prepared a few talking points highlighting their implementation of the law. Then we will have a discussion on progress towards consumer and provider awareness of the law. And then finally, we'll end with the questions and a review of next steps. So for some background, since the Dobbs versus Jackson Women's Health Organization decision in June 2022, select states have enacted laws to ban or restrict access to abortion and other reproductive health services. Currently, around 14 states completely ban abortion, 26 states ban abortion after a specified point in the pregnancy, and 12 states require a person seeking an abortion to wait a specified period of time before they can proceed with receiving care. Now, this is also changing frequently within our current political landscape. And these laws have varying impact on our providers, consumers, and organizations who manage electronic health information. So this leads us to the recent legislative changes in Maryland. Chapter 249, or House Bill 812, is as we often refer to it, Reproductive Health Services, Protected Information and Insurance Requirements, was passed during the 2023 legislative session. The law establishes protections for the disclosure of legally protected health information by health information exchanges and electronic health networks operating in the state. And the law also allows MHCC to impose fines for noncompliance. Chapter 249 generally ensures the health and safety by providing access to safe procedures, upholds individual autonomy and choice in reproductive decisions, reduces stigma and discrimination in healthcare, promotes public health by preventing unsafe abortions and unintended pregnancies, and safeguards legal rights and protections for both patients and providers. Next, we will provide an update on the required regulations to support implementation of the law. Now, House Bill 812 requires the MHCC to adopt regulations governing the privacy and security of the protected health information obtained or released through registered HIEs as well as certified EHNs. COMAR 102518, Health Information Exchanges, Privacy and Security of Protected Health Information, or Chapter 18, and COMAR 102507, Certification of Electronic Health Networks and Medical Care Electronic Claims Clearinghouses, or Chapter 7, are the existing regulatory frameworks to support implementation of the law. Amendments to Chapter 7 and Chapter 18 were published in the Maryland Register as proposed per minute on January 12th. And amendments were then published in the Register on February 9th as emergency regulations. Now, to have emergency regulation status means the regulations are in effect. Emergency status for Chapter 7 began on January 11th and ends July 9th. And the emergency status for Chapter 18 began January 9th and ends July 7th, very close. The Maryland Healthcare Commission will take final action on the amended regulations on April 18th, and we anticipate the final regulations will be published in the Maryland Register in May. And to support HIEs and EHNs implementing the regulations, the MHCC has released guidance documents, which are available on our website. The documents are based on questions we've received prior to the December town halls, and were also updated in February and March with recently submitted questions we've received from many of those on the call. Now, the new updated guidance documents, I want to note that the new questions and responses are indicated in the guidance documents with italics and headers. So if you just want to look for the new information, we tried to make that clear for you to be able to review. So that is an update on the MHCC regulations. I believe we have Dr. Chu with us from the Maryland Department of Health, who will provide an update on COMAR 101108. Dr. Chu, are you with us?
Yes. Hi, everyone. Good afternoon. I'm Shelley Chu. I'm with the Prevention Health Promotion Administration. I'm the director of the Bureau of Maternal and Child Health. And just wanted to echo everyone's work. And so thank you as well. So for an update for COMAR 10.11.8, just as a reminder, back in October, the regulations were pulled back from AELR so that the codes, which were originally in a separate document, in a technical guidance document, were integrated into the regulations themselves. And then the list of included codes were pared down to really focus on induced abortion. So it excluded miscarriage management, ectopic pregnancy, or molar pregnancy as well. So as an update, because of the short period of timeline for the emergency regulations, we weren't able to complete the submission for emergency regulations, but we were able to submit the standard regulations to AELR on November 15th, 2023. And then the regulations were published in the Maryland Register on January 12th, 2024. And so during that time, there was a period of public comment periods. And so we did receive some comments as well. And so we are reviewing the comments received and also having internal discussions and discussions with the Maryland Healthcare Commission as well. So that is the update for COMAR 10.11.08. And I think the other update regarding the Protected Healthcare Commission, which is staff by the department, is also, they also reviewed the proposed regulations. There was no changes requested by the commission. And at that time, some commission members still expressed concerns about the various implementations by HIEs and EHNs as well too. But since then, the commission has formed subcommittees on 2 topics. So the 2 topics are one, gender affirming care. And so they held a first meeting on February 2nd, where the subcommittee members discussed learning more about gender affirming care and further understanding concerns and considerations. And then the second subcommittee was on miscarriage management. So this group is interested in exploring potentially other pregnancy-related care codes. So the next full commission meeting is scheduled this Friday on April 19th. And during that time, each subcommittee will present their progress to the full commission for feedback on this Friday. And so, I think just of note, during the full commission meeting, members of the commission will also discuss the implications of the MHCC regulations on the timeline for additional adding codes. And I think just of note, we have heard the feedback to really focus on the implementation of the current codes before adding additional codes. And so, that is information we will be sharing with the members of the commission as well too. So I just wanted to mention that and just, thank you to everyone who has been really working towards implementing the current codes. And with that, I'll turn it over to you, Hannah.
Thank you, Dr. Chu. Wonderful. So next, I would like to invite Phil and Laurel from Meditech to share a few words regarding their implementation. Phil and Laura, are you on and with us today?
Yes, Anna, I'm here. I'm Laurel Kennedy. Can you hear me okay? Excellent. I'm the manager of the strategic project management team, and I was just going to take a few minutes to go over our approach for meeting and this regulation. So essentially what we did was we reviewed our software to find the areas that we're compliant in, and then we reviewed them again to see if we can ensure and enhance them to provide higher quality for our customers and our patients. So we took each of the regulations and we categorized them into either phase 1 or phase 2. So the first regulation we looked at was the technological capability to filter and restrict. And within our current software, we currently can do that with a confidential flag setting in our software that will restrict the data from being exchanged for that patient. What we're also going to do with this project, which is again part of our phase 1, is that we're going to be introducing a check that will look at the data class elements, and if any of them are a match to the abortion care codes listed in the Maryland Federal Register, we will automatically restrict that data from being exchanged, and all other data would continue to be exchanged. So that is one area that we're looking to change with this project, and that is part of our phase 1 solution. Phase 2 is a little bit more involved. We need to do a little bit more due diligence, and this is around the requirements of allowing the consumer to request and consent to the exchange of legally protected health information to a specific treating provider. So again, in our current software state, there are 2 areas that this can be achieved. One is through our registration process, and the other is through our patient portal. So what we want to do now is take the opportunity to look at both those areas and see if we can come up with an enhanced solution that is most appropriate to ask the patient for consent during the appropriate time, either during their stay or their visit. So we're going to be looking at that workflow to see where we can optimize it for both the patient and the physician. The last one that we looked at was the HIEs must block non-structured health information that relates to legally protected health information and clinical notes. So as you may know, clinical notes and any kind of free text areas are a little bit more challenging than discrete data fields. So what our software currently allows for is we have report templates that can be used so that when clinical notes are entered into a specific report template, that template and that information within those notes will not be exchanged. So that's the current capabilities within our software. And again, we want to use this as an opportunity to further enhance our software in this area and come up with a better solution that would allow narrative data to be flagged rather than using a report template. So that is part of our phase 2 solution that we are looking at. And that is essentially Meditech's approach to meeting and complying with the regulation.
And Anna, could I ask Laurel a question, a follow-up question?
Please.
Okay, thank you very much, Laurel, for going over the work that you all are doing. Again, I'm David Sharp, and I'm with the commission. And my question to you is, these are very advanced technical approaches that you all are contemplating. What is the role of the client in this situation? Because it sounds like there's some agreements, some work that they would have to do to either use the template or to ensure that information is not exchanged in these early days. So how are you working with your clients to ensure that they're actually using it, the technology, the way you've expressed, and at the same time that they are using it? So there's awareness of it, and then there's education on the appropriate use. Can you talk a little bit about that?
Yes, I can give a high-level summary, and I also have other folks on the project team who are on this call that can keep me honest too, that can jump in at any moment. But what we have is we have calls scheduled going on next week with our regulatory team and our customers in Maryland to remind them of these report templates that exist in their current software. They are used right now for a variety of purposes, and we wanted to remind them that they can leverage them for this requirement to exclude those notes from being exchanged. So we do have calls lined up in the following weeks with our customers. And then as we develop and enhance the solution in the future, we will again have calls with them to say, we have a better, more robust, higher quality solution, and here's what it entails, and educating them along those ways in the future.
And is there any concern that these requests that you all are making of your clients are not going to be honored, or are you all using more of an agreement or contractual mechanism to ensure compliance?
That is a great question. How we would ensure compliance. We have messages out on our website right now informing our customers of these regulations and our proposed solutions on how we're going to address them. But you're right, for ensuring compliance, we're going to have to take that as a takeaway to talk with them next week to find out, how we can actually make sure that happens.
Laurel, this is Ben Steffen, and I wanted to be sure that you knew that if you thought it valuable, the staff person from MHCC could speak at this session you're planning. Not a requirement whatsoever, but if it is something you think valuable, please contact David Sharp.
Yes, definitely.
Chris
Excellent.
Kunder from Meditech, Director of Interoperability Development. I have a comment just to add to what Laurel was just saying. I think the challenge really comes down to the narrative data and the reports, right? Like being able to document restricted data in the system. And I think the education really comes down to our customers, right? Like the users of the system need to know that the stuff that they're documenting is sensitive and restricted, and it needs to use this new template, and there's no way for us programmatically to figure that out, right? So a lot of it comes down to making sure that we're, like Laurel was saying, educating the customers on how to use the software, and also what is restricted and what needs to be documented in those sections.
Yeah, and those are great points, and we've heard similar approach from a number of the other HIEs in the state. And while we're here talking to you all, I was wondering if there's any of the other participants that had just generalized questions that may takeaway may help you, and as you all are thinking about your approaches as well, that you'd like to bounce off of Christopher or Laura at this time.
I did have one additional comment to make about the codes themselves. And looking at the code list, what we're trying to do programmatically is to match up the codes that are in the restricted list with the codes that we're collecting and tying to different instances of data in our system. A lot of the codes that we use, though, are tied to the CCD and FHIR API, right? And there's nomenclature that we use to represent medications and procedures and things like that. Some of the codes that are in the restricted list are not the same ones that are federally used when we're mapping data concepts to CCD data or FHIR data, particularly around medication. So I was wondering, and this might have been brought up in the past, but this is just something that we've come across as we've been working on the solution. I was wondering if it's possible that the code list can be expanded upon or reviewed to include RxNorm codes and things like that align more closely with what we're actually associating to the data in our system, because without that, if we have to do a mapping or our customers have to do a mapping, there's just more room for error. So I think that was my proposal, is that maybe that code list can be more comprehensive and it would ease the implementation.
So I could weigh in and offer some historical insight, and that and others can follow. It was considered at one point in time, and what was concluded that these codes would serve as the foundation, and a number of HIEs have looked to popular crosswalks to map the CPT or HCPCS codes to, and particularly the RxNorm codes.
Okay, thank you. And if those crosswalks are available for us to review, that would be very helpful.
And there's a number of questions. So Anna, do you want to read them to our presenters here?
I can, yes. So it looks like the first question is specific to de-identified data sets. Can you provide more guidance about the inclusion of abortion codes in de-identified data sets specifically?
So is this to Laura and Christopher? I'm not sure if this is a general policy question or how the vendor is using it. So why don't we come back to that for a moment? And if Mary, you could help us to figure out what angle you want us to answer this question, that would be great. We'll come right back to you. So I think Lee's asked the question, Anna. We can.
So it looks like Lee's statement is software developers cannot ensure compliance. We can provide guidance. We can clearly educate on the steps clients should take within the product to effectively support the intent of the law. But the users ultimately make decisions that are out of our control. And this is a critical element of the complicated challenges that should be minimized.
And I think we've heard Laura and Christopher talk a little bit about education. I think that one of the things we noted, or Anna noted, at the beginning, was that the way the law is designed, the responsibility for ensuring compliance first rests with the HIEs. And I think, and EHNs, and what we're hearing is that, as our executive director noted early on, there was lots of concern that this couldn't be managed. And what we're seeing is considerable progress to meeting that challenge. Is it perfect yet? Is it 100%? I think the answer to that, both of those, is no. But are we well on our way as an industry? I think the short answer is yes. So I think, Lee, this is a good point you make, and you've certainly not been shy about expressing that in the past, and we appreciate your willingness to keep pushing that out there. But what we're hearing from folks today, certainly from Meditech, is that they're staying vigilant and trying to make sure that their clients are well educated. And that goes a long way to ensuring that we get compliance in absence of having technical solutions that can do this work for us today.
So David, I wanted to circle back to Mary's question and say that we need to think about that. There are particular requirements that providers have to meet that an HIE may perform on behalf of a client. So we need to think about that before we speak. If you have any more specifics, Mary, you can share with us in an email. That'd probably be helpful.
Yeah, I think that's a good point, because I'm a little not sure exactly the use case that you have in mind, Mary. So maybe to Ben's point, if you can articulate that.
I think it's an important question that you raised, but it also is a function of who the receiver of that information is. So I don't want to speak too quickly before we've thought through this.
And I think Sasha is asking a couple questions. See, I agree with, let's start with the lower one. I agree the industry is working very hard on protecting privacy of Maryland patients, but the structural law focuses on HIEs remains limiting. To really achieve the privacy protections that are desired will require the cooperation and engagement of Maryland providers as well. And I think no one would disagree with that. I think that's a very good point. And I sort of recall hearing the Meditech folks in roundabout ways say just that. But thank you, Sasha, for that point. Other questions, or we can continue to move on. Okay, Anna, back to you. Thank you, everyone. Great questions.
And we will have a few other discussion questions for you soon. But I want to thank Laurel and Christopher for sharing from Meditech. We really appreciate your update that you were able to share. We also want to thank everyone who submitted an implementation plan earlier this year for submitting their status reports. After reviewing the reports, we found that around 54% of HIEs will have the technological capability or policies to suppress the codes released by the Maryland Department of Health by June 1st. And we anticipate an additional 23% to have the technological capability or policies by the end of the year. And the remaining 23% are anticipated to be able to suppress the codes after 2024. And HIEs have farther to go when it comes to suppressing text-based information by June 1st. Many of those who are able to suppress it by June 2024 are leveraging existing technological functionality. 8% will be able to suppress text-based information by the end of the year, and the remaining 77% after 2024. So the MHCC is drafting responses to your status reports, and we hope to provide those responses by the end of this month. We thank everyone for their careful consideration in your submissions. So with that, we do have additional discussion questions for those on the call today. We would like to discuss the implementation of the regulations and specifically building on the earlier conversation that David started regarding consumer and provider awareness and transparency. So the previous table highlights those efforts that y'all have been working very hard on for the technical or the policies to suppress legally protected health information. And we're hoping to hear a little bit more from those on the call on your efforts to disseminate that technology or those policies to clients. So we've heard from Meditech, and thank you again, Laurel and Christopher. Excited to hear how that call goes. Could others share on the call any successful communication efforts you've been able to implement or have planned to inform clients and healthcare providers of your upcoming technology updates?
And those who've worked with me in the past know that I'm not very bashful about reaching into groups and asking for contribution of ideas. So I might open it up and invite Ken Whittemore to the conversation from SureScripts. Ken, can you make a comment to Anna's point? Okay, we'll go on. Anybody else wants to sort of weigh in, and I'll look for friendly names that I see on the list. Seems like a shy group today.
I think we have Vina from Oracle Cerner on the call.
Oh,
Vina,
wonderful.
can you share a little bit about Oracle Cerner's efforts in reaching out to clients?
Yeah, I can share a little bit. So we've kind of taken a very similar approach with our Maryland as well as California clients because the regulations are very similar, and in our solution it will apply to both states. So what we've been doing right now is we created a client version of our implementation guide, very similar to the plan that we submitted to the Healthcare Commission. We created a client version of that with kind of a step-by-step and screenshots of what they would do to implement our current functionality, and then kind of a description of our longer term plan. So we kind of distributed that to our clients, and then based on that, we kind of been meeting one by one with clients to start to go over the plan, and then just answer any questions they have. And so that's kind of been our approach right now. And really, we're looking for feedback from clients right now to kind of see what their thoughts are on the plan. And we're also going over our longer term approach, which I believe many of the vendors are taking that kind of current functionality and longer term approach. So the longer term approach is really what they become more interested in, because that is really the more robust approach that's going to meet not just this regulation, but a lot of privacy, confidentiality, consent concerns, that's come up in the industry at large. And after we kind of get through these one by ones with clients, we're hoping to get kind of a bigger group together of just Maryland clients or California clients. And that'll kind of, hopefully with the feedback we get, we'll start to update and edit our implementation guide for clients and kind of use their feedback to alter our approach if necessary. So that's kind of been our plan so far.
And Dina, have you heard comments from your clients in that maybe more concerned about trying to implement these requirements, or there seems to be a much broader willingness to go along and to try to comply with what you're asking of them? Is that?
Yes, I think for the most part, everybody's very willing to kind of meet what they can. We've had a couple clients, I'll say more on the California side, because they get into that gender affirming care topic, and we have clients that kind of have a very large adolescent population, and so this is of a concern for them. And so they've been asking for that technology. Of course, they've been needing it longer than this regulation has come out. So they're also looking at our current functionality, but they're also looking at some other approaches, that they take similar with what they're doing right now for behavioral health notes. Because the current functionality is not perfect. And so some people are wanting to take a more conservative approach on their end. And of course, that's their choice to do that. But for the most part, everybody is really looking to that longer term plan, because that is the more robust plan. But of course, that's going to take time.
Let's see. And you mentioned behavioral health. Can you sort of note how you all handle the part 2 requirement?
Yeah. So that is, so right now that's kind of we treat that kind of as a separate note, a segmented note. And so because it's segmented, it's separate, and any release or disclosure of that is very is reviewed, and it's a little bit more manual of a release, since there's more regulation and you need more eyes on it. So that does kind of separate the whole note, versus with the structured information, the narrative, or the unstructured, I guess. So but again, that doesn't necessarily meet the requirements of this regulation, but that's the approach that many take when it comes to behavioral health.
I see. Okay. Anyone else in the group have questions here for our friends from Oracle?
Just a follow-up to what Vina said. This is Katie Eagle with Oracle Health, and I work specifically with our Maryland clients on interoperability. And when it comes to behavioral health, we actually do filtering out by facility. So if there's a specific visit or procedure that's at a behavioral health facility, we don't generate a CCDA for sharing that out to a state HIE or to Commonwealth Care Quality, any kind of network sharing. So that limits pretty much everything within those facilities that happens. If you have a non-psych location that has psych visits, then we look closer in doing it like at the note level and things like that, like Vina mentioned.
Let's see. So, but you also are able to block by a facility basis.
Correct.
Interesting. And is there concern? I'm just curious. Is there concern amongst providers about blocking the record completely at a facility level?
Most of our clients have a behavioral health facility and feel that that information should not be shared in common networks, out for data sharing, but rather be the choice of the patient or, a joint choice of their psychiatrist and patient of who should get that information.
And I don't mean to go deep into your technology, but I'm curious, what about the medication record? How is that treated?
So today we're mostly sharing CCDA level documents, and basically we don't generate a CCDA level document to send outbound to share. They get a CCDA document that is storable in their local chart and references everything about that patient visit. But when we filter based on facility, it's basically an all or nothing approach there. Whereas again, if they need to filter certain things based on codified values, that's where we kind of get into that more nitty-gritty filtering out.
Okay, very good. Thank you very much for that. Anna, if you're familiar with some of the other folks, you might want to try to pull a couple other commenters in if you can.
Sure. Yeah. I know, Lee, that you've shared a little bit earlier about Altera and working with your clients. I thought you had some really interesting information in your status report about specialized communication regarding your technology updates. Would you feel comfortable sharing a little bit about that?
Yeah, I mean, we just, following different meetings with the Maryland team, we've had a lot of conversation, and this, encompasses EHR Association meetings as well. We've had a lot of conversations about the provider obligation in this process. I mean, we cannot do all of this for them. I'm not going to back down from saying we can not do everything that is required by this law at this point. And so while we work towards that compliance and, take that very seriously, we also are actually just finalizing a communication that will go to clients that really tries to make clear to them what their part in this is, and what they can do, what their providers can control in terms of how they choose to document, how they choose to share information or not share information. We can't force compliance, as I said in the comments, don't have a way to do that, but we do want to educate them. What we're really doing is taking an educational approach of, do you know the product and where you can do this? Do you know what we've done? Do you know what the law says? We'll kind of go from there and partner with our clients to answer their questions as well.
That's fantastic. Thank you, Lee. And I certainly would applaud you. You all have made great strides in really progressing on the implementation requirements. And I know it's been a it's not been an easy one for everyone, and you all have noted some of the challenges, but multiple efforts on your part. So I just wanted to make that known here as well. But you mentioned something. I'd be curious if there's other EHR HIEs that experience this. If you're creating upgrades to your software and rolling them out, are there instances where you all are finding that some of your clients are reluctant to implement them for lots of reasons? Some of them may be very good, some of them may be a bit of a head scratcher to you, but are you finding these kinds of challenges?
I mean, I will start by saying I think generally in the industry, providers are fatigued by the upgrades or changes or whatever, different companies call things different names, but regulations, both from the federal and the state level, are forcing providers to take new technology and to make changes way more frequently than they want to. And so, I think that is a large theme that many vendors are feeling. And so when we go to them and say, hey, you need to take this, some of them are like, just went through that, have to go through it again in, 5 months because of an ONC certification change or whatever it is, right? And are therefore resistant sometimes. We haven't had that conversation specific to Maryland yet, but just overall, I think that's a theme in the industry.
Yeah, that's not an unheard of concern, and it extends more than just technology changes. It's providers are faced with lots of challenges and being pulled in many directions. So I do note the comment that Sasha made here, which is important, and we definitely appreciate her insight to the challenges they're facing. She noted that while the law, essentially what she's saying is it requires the cooperation and engagement of Maryland providers as well. And a good sense so far is that from the presenters, those who have spoke on an ad hoc basis, we're hearing that probably it's safe to say there's more support than reluctance. Although I think Lee has noted the support may be a bit on the exhausted side, but there's support. And I think you're right, Sasha, that it does require the Maryland providers to really get behind this. And I think you're in good company, because it sounds like this isn't just a unique to any particular solution, but it's more broadly an effort of what we heard some of what the folks from Meditech say is it's education. And that requires a lot of energy. So we recognize the challenges that the folks from Epic have noted and appreciate their good work to keep advancing that cause. I see a couple other questions to the point that Ben raised earlier. Mary is saying, so to clarify, we were asking about the obligation of HIEs to scrub abortion codes from our de-identified data sets. Typically, data is not considered PHI. This data is not considered PHI because it can't be tracked back to the person. So, I think let me just pause and see if Ben, if this helps in terms of what you were getting at. I feel like this is something we probably have to take offline, but I don't know if you wish to comment.
Yeah, I think that, thank you, Mary. That I think you've expanded on a point that I was thinking about too, that my gut reaction would be to read it in some ways similar to you, but I want to discuss this in the context of the new law with our assistant attorney generals to make sure that we're all in alignment before I give you any formal direction on what we think you should do. But I think that it's helpful to clarify what you're thinking.
Okay, Anna, I think we've hit on all the questions. Oh, there is a couple others. One gentleman is saying essentially to double down on Lee's comments around the challenges and structures, as there's no client obligations. I think that's a well-known fact at this point. I think it does require energy and a lot of good work, and I certainly think that folks at Meditech, what Laura presented as an example of how hard you have to work to really help move this along. But there doesn't seem to be as much reluctance as, what one might think. We're hearing that the clients seem to be open to, education and guidance here as well. So, so that's important, to note. And I think Sasha Teramont from Epic has raised a question here. And I'll just sort of summarize. I think the next step to promote Maryland patient privacy is to convene all the stakeholders together and discuss what can be done with technology and what relies on how the technology is used. There are roles for creation of new technology features, but there also seems a lot of privacy initiatives that is dependent on the healthcare provider community to upgrade technology, use technology as intended, and talk with their patients about choice at the right moments. Yeah, I think everybody would easily agree with that. And I believe, if I recollect correct, the association with the Electronic Health Record Association, there was some discussion about how convening a more larger group of technology vendors to start in terms of getting these conversations going and then broadening it out a bit might not be a bad idea. So I think there's more to come on that. But thank you, Sasha, for that feedback. And we have Stephanie Jameson on the call she's of course with one of the EHRs, but she's also from the association. So I don't know if there's anything, Stephanie, that you wish to add at this point.
No, I think Sasha and Lee have stated very well our general concerns that we've had from our EHR association members. We're a 29-member association, and we've had an extraordinary amount of discussion and on various work groups. Public policy just met, for example, and we spent probably 30 minutes talking about Maryland and our challenges, and we've been, I think, doing a good job of trying to get as much information that we're receiving from the commission and you, David, to our members and vice versa. And we've set up a quarterly meeting cadence starting a couple of weeks ago. And I think that is been a valuable channel to start the conversation between our organization and your organization, especially on behalf of our smaller member companies that don't often have the bandwidth.
Yeah, and thank you, Stephanie. Again, we appreciate your engagement, both for the industry and with us here as we try to do what we can to work collectively to get this requirement implemented broadly across Maryland. Anna, do you want to continue us onward from here?
I can, yes. So the next portion of the agenda was to ask if there were questions related to consumer and provider awareness and transparency, and I think we've covered those. If you do have more questions about that, or interested in hearing from others, please reach out to me directly. And if you have any questions similar to the one that Mary raised, please send them to us, and we're happy to work with you and answer those questions. And Andy, to kind of get to your next question regarding timeline, I can share a bit about next steps. So thank you everyone for that conversation. So as a reminder, validations are due June 1st. We will be sharing guidance regarding the submissions of those validations with all of you. And as I mentioned, we are also working on the responses to your status reports that we received. We do plan to host a town hall in May to further discuss the validation requirements as well as the HIE registration renewal process. including some guidance on requesting exemptions. And Andy, to address your question directly, I believe correspondence went out a few weeks ago regarding registration renewal process. And we requested at that time that HIEs who are up to renew their registration submit their application materials by June 14th. And then looking at other questions.
So I think the question about provider education, Lee's asking about the role of MHCC or other state agencies to educating providers. And I would say from our perspective, we certainly have been ringing the bell of education, but we've been spending our time largely centered on helping the HIEs and EHNs to better inform them on the education requirements and helping them to reach into their client listings, if you will, from Maryland. They would have the best connection on who they are and what uniqueness is to their software solutions that need to be deployed. We have done a great deal about building just general awareness, but as it relates to the system-specific requirements, that seems to be best served by each one of the HIEs or EHNs. And
Yeah, David, if I can just chime in on that, you know, I think a lot of us are working to educate, but there would be a different receptivity maybe from some organizations if they heard it from the state as well. I think the state does have an obligation to work with, you know, the medical association, to work with the hospital association in the state, and, you know, really push that message out, because things are just received differently sometimes when it comes from us than when it comes from you all.
Very good point. Very good point. And we will absolutely take that back. We do have representation from the Hospital Association on the call. We might be curious to know if they're, as in the association, are doing anything uniquely to them, to their members.
Sure. Good afternoon, all. This is Diana from the Maryland Hospital Association. So we are actually working actively, and as David and Ben and Anna and Nikki know, as well as Sasha, we're working actively, at least with a small group of members, to sort of address some of the concerns with one of the EHRs that have a larger footprint among our membership. But I think a lot of it is coming down. Of course, we have, you know, spread awareness of the fact that this bill passed and it will be affecting everybody. It's more that given that there is still some unknowns in terms of the implementation plans and the differences between the different vendors, we are gathering that information, and we are working closely with our members to identify, you know, what the process is in order to implement these, in order to get these upgrades to their EHR that will comply with this system. And we're working very closely with David and Ben and Nikki and Anna to make sure that, you know, that we're all in lockstep in terms of communication and questions about the burdens and hurdles and any areas for improvement.
Okay, thank you very much, Diana. And there's a couple questions. Let me just sort of touch on those. Sherry Medina, if you could just send us put your email address here in the chat, we'll follow up with you offline, because I think we want to understand a little bit more about your question. It may take us a bit more time here. So if you could do that, we'll follow up with you. And Keith asks a question saying a good topic for next town hall would be patient safety. When EHR companies express concerns about technical limitations, they are primarily talking about the limits of what we can do with technology without causing harm to patients. It would be helpful to hear clinical leaders from your organization address the risks and harm if information blocking is not done precisely. So I think that's an interesting comment we've heard we've heard a lot about that in the past, and it's a tricky balance, and there isn't a good one-liner that makes everyone feel good. But we have Dr. Chu from the Maryland Department of Health with us, and I wondered if this might be an opportunity for her to comment. So, Dr. Chu, are you still with us? I think I see you there.
She
Hi,
may have
everyone.
stepped okay.
Oh yeah, I'm sorry, could you repeat the question again?
Sure. So the question is, when EHR companies express concerns about technical limitations, they're primarily talking about limits on what the technology can do. And what Keith is asking would be helpful to hear from clinical leaders as it relates to the risk of harm from information blocking if it's not done precisely.
And I'll say, I'm suggesting this as a fulsome topic for a conversation, not something to squeeze in at the last minute of the meeting, but thank you, Dr. Chu.
Yeah, I mean, I think, let me just, add that I think, the steps we've taken to say blocking entire records, we don't believe are consistent with the intention of the law, and we would not accept that as a solution. I too think we need to pause and think about that, even though we're not going to agree that blocking entire clinical records are a solution. We'd like to talk internally, and I think the topic for the next meeting is appropriate to put that on and give us some time to think about that, how we would guide you. But I'll turn it over back to Dr. Chu if she has anything more to add.
Yeah, I think that would be helpful. I think just to have a fuller conversation, and maybe that is something that we can have as a follow-up conversation. I know that we've also have had, I think, some discussions with partners too about blocking and the concerns with blocking full records as well too, because it limits the coordination of care as well too. And so, my also understanding is that that is not the attention of blocking all the records as much as the specific records as indicated in the bill as well too. So, there were concerns that our commission have brought up too about if full records are blocked, about that continuity of care.
Right. So I think we have
Yeah, to re-emphasize, anyone can, I think we put a pretty strong no on is our solution of blocking records permitted, and our answer is no. But I think Keith's question is more narrow, but to use his words, not exactly precise. We to vote for as much precision as we can absolutely get.
And so I'm not sure, I think as to our executive director's point and Dr. Chu, discussion is always going to be good on this matter, but I think it's a tricky one because what we have heard in the past is some vendors would prefer, maybe taking a strategy to block all information. And in our guidance document, we've been fairly clear, as Ben noted, to say, we don't believe that's meeting the compliance of the law. And we do this in a couple of places in the guidance document. Will some information be blocked? And I think we're hearing the answer to that is yeah. I mean, that's, as Dr. Chu mentioned, the requirements in the law. So I think having more conversation is good, but I'm not sure we'll walk away with everybody saying, oh, there's the perfect balance or the perfect answer. This is a tricky balance to walk, and there are states that are implementing these kinds of laws. So it's, we're seeing more and more of it, and we just have to be mindful of that in Unfortunately, there's not a perfect answer.
Yeah, all of the comments that are kind of coming in now in a swarm are thoughtful and insightful. I think your suggestion, Keith, to make it a topic next month, is one we're going to strongly consider.
Okay, thank you all for your feedback. Anna, back to you.
Wonderful. So just as a reminder, we will be sharing more guidance about the validations and the HIE registration renewals. And before we conclude the meeting, I didn't know, Ben, if there is anything else you would like to share in closing remarks.
I just want to again thank everyone for their attention throughout this meeting, and looking forward to the call in May. We'll have some more important information. The guidance documents, David said repeatedly, are your trusted source of information. So please review those, and if they don't give you the answer, reach out to David Sharp and his team, and Nikki and Justine and Kelly.
Thank you, Ben. David, would you like to share a few words as well?
I would just like to echo Ben's remarks. Thank you all tremendously for your time and attention. Every question is a great question. Please do not be bashful about sharing us with your thoughts. They're meaningful, and we are not going to sort of step over them. And we're very grateful for the time that you all are taking to share your ideas. And we're also very impressed by the hard work that you all are doing and have done to get this far with the implementation of the requirements that are established in the law. So thank you for your time today, and wish you all a great rest of the day and a wonderful week ahead. Anna.
All right, thank you all. And here's my contact information, as well as contact information for the Maryland Department of Health if you